Hello, everybody, and welcome to the approach to an unconscious patient. During the last class, I explained to you what may be the causes for why a patient may be unconscious in the ICU or anywhere else that you might find an unconscious patient. Welcome to the third in the series of classes by me. This will focus on how to approach a patient who is unconscious or appears to be in a state of altered consciousness. You may be a medical professional or a new medical graduate or a non-medical person. But the series of steps that are required to identify and manage a patient is the same if you want to make a difference to the life of a patient who is unconscious. This class module will cover the following steps. It will cover what the airway is all about, how to make sure that the airway is patent while you approach the patient. It also tells you about how to establish breathing in a patient for someone who cannot breathe by his or her own self. It will also tell you how to establish circulation in case the circulation of the patient has been stopped. The first step you would do when a patient is unconscious is to stabilize the patient or to prevent the person from being pushed further into unconsciousness. That is the point of no return. If a person has drowned and is in a water body, you will have to pull the patient out of the water body to dry land. If the patient is undergoing an electric shock, it is important to switch off the source of electric current, and that will be the first step. If a patient is consuming alcohol or an illicit substance, you will have to remove the substance from the person and identify it. Drugs and medicines have antidotes that can reverse the symptoms that the patient is displaying. The first step will be to identify the substance and quantify the volume of substance that the patient has ingested. If the patient has had a fall a few days back or a trauma, has anyone witnessed the fall? Or was anybody around to notice the mechanism of injury that the patient suffered? All of these are clues that will help to identify the level of care required to attend to the patient. So medical practice, it chooses to simplify things. Some of the jargon that can be quite overwhelming. And so we can choose to compress the first steps of resuscitating a patient into an abbreviation. Anesthetists and critical care physicians use the ABCDE algorithm. A stands for managing the airway and breathing, helping in correcting hypoxia and causing a decline in sensorium. A stands for the airway. This is the path that air takes to the lungs. It needs to be clear so that the patient, if he is semi-conscious, can take the air into his lungs with his own effort. There can be conditions where the patient has ingested food and it lies in the mouth. The tongue may fall back into the mouth and prevent air from entering the lungs. As a primary responder, you can remove the food substance or liquid in his mouth. Anesthesiologists use a device known as an airway, which is made of plastic. It is a short 10 centimeter thick curved tube that is placed inside the mouth and over the tongue. This allows air to move into the body without any obstruction. This is the maneuver used to make sure that the air that reaches the lungs moves in without any problem. This will help air to move in freely into the lungs via the windpipe. So intubation is a process by which we introduce a plastic tube into the lungs. There is something known as the Glasgow Coma scale, which assesses the degree of unconsciousness that the patient has. If the score is less than 8, then the critical care physician or the anesthesiologist will insert a plastic tube into the windpipe. A few other people may have a benzodiazepine overdose, which means an overdose of sleeping tablets. These people need to be watched and monitored over a period of time because most of them come out unharmed. This is known as the Glasgow Coma scale. So when a person who's unconsciousness is brought to the emergency or to the ICU, the emergency medicine physician or the anesthesiologist will assess the Glasgow Coma scale score of the patient. It is based on 3 parameters, that is the eye opening, the verbal response, and the motor response. Let's say the patient is talking to you spontaneously, then he has a score of 4, which stands for E4. If he responds to you when you talk to him, then you can give him a score 3. Let's say he's not responding to you, and let's say you pinch him, and then he starts responding and talking to you, then you can give him a score of E2. If the patient is unresponsive and does not open his eyes, then there is a no response. You will also have to consider how he talks to you. Previously, what I discussed was how he opens his eyes. And E3 stands for when you talk to him and then he opens his eyes. Let's say the person is conscious and oriented in time, place, and person. Does he know where he is? Does he know what time it is? Does he know whom he's talking to, and does he know his name? And can he introduce himself? Then he's known as V5. If he is confused, but he's still oriented to time, place, and person, then you can give him a verbal response of 4. If he's talking about inappropriate words, then he receives a verbal response of 3. If he mumbles to himself and you cannot understand what he's saying, then he can be given a verbal response of 2. If he doesn't talk at all, that is known as no response, and he's given a score of 1. Motor response refers to whether he is moving his hands and limbs and eyes and head all according to what is considered normal. If he obeys commands, you ask him to lift his hand or hold your hand, then he can be given a motor response of 6. Let's say you pinch him over his hand, and he moves his hand towards the place where he's been pinched. Then it is known as a motor response of 5. Let's say you pinch his shoulder, and then he pulls his hand flexes his hand towards the area where he's been pinched. Then it is known as flexion withdrawal from pain. That is given a score of 4. Abnormal flexion is when you cause a little pain to him and his upper limbs are flexed up like this. That is when he is known as decorticate, and he is given a score of 3. Let's say even after giving him a certain amount of pain, all of his hands and legs are completely extended and he does not move. That is known as decerebrate posture, and it's given a response of 2. Let's say even after talking to him and causing a certain amount of pain to him, and he still remains unresponsive, it doesn't move his hands and legs, he's given a score of 1. The best response, or a person who is normal, is given as 15 by 15, meaning his GCS score would be 15 by 15. A person who's completely unresponsive is given a score of 3. And a person who is known as comatose is known to have a score of less than 8. And such patients are supposed to be intubated in order to give them oxygen to their lungs and help them breathe. Let's say a person has intracranial hemorrhage, which means a bleeding through the brain, and his sensorium, his consciousness falls from a GCS of 14 to 8. Such a patient will need urgent intubation and mechanical ventilation. It is also important to stabilize his cervical spine, which means the patient may have a fracture in his vertebrae in his neck. So it is important to stabilize the neck before you consider intubating the patient. There are moments and conditions where the patient stops breathing. There can be moments when the patient stops breathing in deep sleep. This occurs in patients who are obese and in a condition called obstructive sleep apnea. The first step here will be to try and wake up the patient. Patients in the ICU or the emergency are made to sit up and are asked to be alert and responsive. In certain instances, when the patient does not breathe, the physician will try and evoke a response. You can ask the patient, "Can you hear me?" or nudge his hands or face. If these fail, you can force a response from the patient by pressing their nail buds or by pressing their sternum, that is their breastbone, with your fingers. Such maneuvers will cause a little pain to the patient, but that is one of the ways to make the patient responsive. If the patient's head is falling on his chest or lying on his side, the anesthesiologist use a maneuver called head tilt and chin lift maneuver. This will cause the head to fall back, prevent the tongue from falling back into the throat, and allow air to flow into the lungs. This will allow the patient to be stimulated and allow him to start breathing spontaneously. This is the second step to establishing oxygenation of the tissues. If the patient is not stimulated to breathe properly, the patient will have to be given artificial means of breathing. The first step will be to apply a mask on the patient's face that covers his nose and mouth and connect the face bag to an ambu bag, which is further connected to an oxygen supply. This is a procedure called bag mask ventilation. The ambu bag is a plastic self-inflating bag that, once compressed, inflates by itself and takes more air into it. Compression of the bag forces air into the lungs, causes oxygenation of the tissues. Oxygenation of the tissues and brain will help the patient regain consciousness. In case this fails or the bag mask ventilation is difficult, the patient will have to undergo intubation and mechanical ventilation. This is the sequence by which an anesthesiologist uses a device known as a laryngoscope to open the mouth and view the vocal cords beyond the tongue, insert a plastic tube inside the vocal cords and into the trachea, and then connect the tube to a ventilator. There are instances where the patient may have fallen from a height or may have been faced with an injury to his spine on the neck, when this happens, it is a critical moment because injuries to the cervical spine can decide whether the patient may be paralyzed from the neck down, a condition known as quadriplegia. The cervical spine or the neck is to be kept immobile, and even while shifting the patient, the neck should be moved in line with the head and shoulders. Intubation of such patients should undergo a process called manual inline stabilization of the cervical spine. Some anesthesiologists use a procedure called fiber optic intubation, a process by which a camera at the end of a tube that is known as a fiber optic bronchoscope is inserted into the trachea, and the plastic tube is inserted along the bronchoscope and into the trachea. All of this is done without moving the head and the neck, which pose a high risk to the patient. Now, the ventilator delivers oxygen at a certain pressure and volume. Normally, a person breathes 12 to 14 breaths a minute. An adult male breathes close to 500 ml in a single breath known as a tidal volume. So anesthetists calculate what is called a minute ventilation. That is the total volume of oxygen or air that enters and exits the lung in 1 minute. So let's say you breathe 12 times a minute and take 500 ml during each breath. your minute ventilation will be 12 breaths per minute into 500, which comes to around 6,000 ml or 6 liters in 1 minute. Once the patient is in the ventilator, the settings are adjusted in such a manner that the patient receives that amount of air or oxygen. The patient most likely recovers from unconsciousness in case he has fallen unconscious due to hypoxia. In a few cases of drug overdose, the patient may be breathing but be unconscious. The approach then will be to see if the patient wakes up after a certain period of time. The oxygenation of the patient anywhere is measured by the use of a device known as a pulse oximeter. This measures the pulse rate and oxygenation of tissues at the tip of the finger. The pulse rate can vary between 60 to 100, and the oxygenation is said to be adequate if it is greater than 95%. If the patient is seen to gradually slip into unconsciousness in front of you, or if you notice that his breathing is constantly slower and of a lesser depth, this is another reason for intubation and mechanical ventilation. C stands for circulation. This is the manner in which physicians identify if the heart is the issue. Is the heart beating properly? Is it pumping regularly, and is enough blood being ejected out of it? Does the blood reach all the vital organs such as the brain, the heart, and the kidneys? If the heart itself does not get enough blood supply, then it won't be able to pump well. This is when the physicians check the blood pressure of the patient. Unconscious patients who have not been tended for a long time possibly have a heart that is weak. Unconscious patients may not have eaten or ingested fluids for a long time. He or she may have taken medication that can cause their heart to slow down and not beat in a regular rhythm. Professionals first establish an intravenous catheter into the veins of the unconscious patient. They start infusing fluids in the form of saline. The fluids in the hospital generally use what is known as normal saline, a particular concentration of salt and water. Salt because it is vital to the function of neurons in all the tissues in general. This will initially help to increase the blood pressure of the patient. Blood will tend to flow to the vital organs such as the brain, the heart, and the kidney, and the patient may wake up. In case the patient does not achieve adequate circulation, physician will use drugs called positive inotropes or vasopressors. These are a class of drugs that will increase the contraction of the heart, increase the speed of contraction of the heart, and also increase the blood pressure in all the blood vessels arising from the heart. Another common reason for why the patient may be unconscious is hypoglycemia. When the person has glucose values which have fallen much lesser than normal, the glucose in their body needs to be replaced. Glucose-containing solutions such as dextrose in different concentrations are available in the hospital. These may be in concentration of 5% or 25%. Either of these may be used to increase the levels of glucose in the blood and waken the patient from a hypoglycemic coma. What you see here is known as a normal sinus rhythm, where the heart beats regularly and has fixed time intervals between each beating of the heart. There may be times when the heart beats irregularly. This may be a reason why inadequate blood supply and oxygen reaches the brain, leading to unconsciousness. In such scenarios, the physician will inject a drug that can regularize the heart rate. These are called antiarrhythmics. There are certain cases where the beating of the heart is reflected on the cardiac monitor, and this shows a condition called ventricular tachycardia or ventricular fibrillation. This occurs when the heart, instead of beating at a regular rate of about 80, starts beating at rates greater than 150 beats per minute and very irregularly. This is when the physician can decide to defibrillate the heart. He or she will apply electrodes on the chest and the sides of the patient and then administer a shock of electric current to the patient. This will help stun the heart and restart the heart with its natural rhythm. This may be done by a medical professional who is trained according to the ACLS protocol, which is the Advanced Cardiac Life Support, a certification course designed by the American Heart Association. This is how the pads are applied in case one wishes to defibrillate the heart. And this is known as an defibrillator that is commonly available in the ICUs or the emergency ward of the hospital. Coming to what D stands for in ABCDE. D stands for neurological disability. The first step here will be to assess the level of unconsciousness using the GCS scale. The GCS stands for the Glasgow Coma scale. The Glasgow Coma scale is important to observe and communicate trends in a patient's condition. The scale was described in 1974 by Graham T. Stale and Brian Jennett as a way to communicate about the level of consciousness of patients with an acute brain injury. The scale assesses patients according to three aspects of responsiveness, that is the eye-opening, motor, and verbal responses, like I have mentioned to you before. The score expression is the sum of the scores as well as the individual elements. For example, a score of 10 may be expressed as GCS 10, E3, V4, M3. The assessment of responsiveness with the Glasgow Coma scale is widely used to guide early management of patients with a head injury or other kinds of acute brain injury. The decisions in most severely impaired patients include emergent management such as securing the airway and triage to determine the patient transfer. The decisions in less severely impaired patients include the need for imaging the patient, which is identifying what is wrong with the patient's brain by using an MRI or a CT scan, and to decide whether you have to observe the patient more or to discharge the patient. To find out the Glasgow Coma scale over a period of time and repeatedly assessing the patient will help in monitoring the course of the patient in the hospital and to guide the changes in management. While you are doing above, that is assessing the patient's response to your command and stimulation, you should also check his pupils, the tiny black circles in the center of the patient's eyes. Pupils normally contract or constrict in size once light is shown on them. There are certain conditions where the pupils are dilated or certain other conditions when the pupils are constricted. Pinpoint pupils are seen in a condition where the pons, that is the structure on the back of your head, the brainstem, is affected. Dilated and constricted pupils indicate that the patient may have consumed a particular drug. The actions of the drug decides whether the pupils are dilated or constricted. Also look for whether the patient has decreased movement or power on either of his sides. Patients with a stroke may have weakness on one particular side of their body. Some others may have involuntary movements, which indicates that they may have a seizure. E stands for exposure. This is a quick head-to-toe examination to look for trauma or petechiae, which are patches of red or rashes on the skin. Infectious sources such as a catheter, which is inside the body, or needle pricks in intravenous drug users, or transdermal drug patches. So the ABCDE describe how to approach an unconscious patient. If you can identify and apply what you have learned in this class, you will be able to help the patient reach the emergency medicine physician or the doctors in a better manner. The treatment at the hospital will be faster, and they will know exactly how to get the patient back on his or her feet. This speaks about what is known as a head-to-toe examination. It is divided into two segments, that is the primary survey and the secondary survey. The primary survey contains all what I have taught you in this class, which is ABCDE. A stands for the airway and cervical spine control to make sure that the airway is patent. Log roll is a procedure by which you identify whether the patient has had a cervical spine injury or any spinal injury. Make sure that the patient is breathing spontaneously. That is what B stands for. And circulation is to find out whether the patient needs drugs to make sure that the heart is beating properly and his blood pressure is fine. It is also important to look for any trauma in the abdomen or any of his bones have a fracture. Disability stands for neurological disability, in which you assess whether the patient has a head injury. You can check his pupils, check whether he has any dislocations of his body, and to check whether he has any nerve injury. It is important to make sure that the patient is exposed so that you can assess the patient well and to assess the environment that the patient is in. Also look for any heat-related illness or cold injury that may occur to the patient. The secondary survey is a head-to-toe examination. You will have to check his eyes, ears, nose, teeth, gums, his respiratory system, his cardiovascular system, his abdomen and his genitourinary examination, a musculoskeletal system examination, and a neurological examination, including to find out whether he understands what you're saying and he can respond to you intelligibly. In case the patient may have a fracture or a sprain, you may follow what is known as an abbreviation called RICE. That part of the body needs rest, it needs ice, it needs compression in case there's bleeding, and it needs elevation from the rest of the body to prevent further bleeding. In case the patient may have a fracture, you may need to splint the part of the body. The patient may need crutches in case he needs to move from one place to another. And in case you're in the emergency medicine department and you don't have an orthopedician or a trauma response team there, you will need to transfer the patient to a hospital which contains a trauma team and has an orthopedician on call. Let's say the patient is an athlete and this is an injury that is not very serious. There are three things that you can do. One, you can observe the patient to see whether he or she can get back to play or return to playing the sport. If the patient is absolutely cannot get back to his sport, then the patient needs to be transferred to a facility where he or she can be treated effectively for the particular concern. Thank you for joining me on the third class, which is the approach to the unconscious patient. See you on the next class.